There we go. We're at 210 participants, over 210. We're going to start this event. Welcome, everybody. We're proud and happy to have you here. And I'm going to do a couple of introductory slides before I hand over today's webinar to our president of ICOPLAST, which is Julio Kirschbaum, and a special event. So let's start, before not to spend too much time on other things. So ICOPLAST, what are we about? Do we have any disclosures? No, we do not. We are supported and founded and funded by our members. I am going to show some QR codes, so have your camera stand by so you can quickly access the websites that we're showing. I'm Hinne Rakhorst. I'm your co-host today with Julio Kirschbaum, our president. I have nothing to disclose, no connections to industry whatsoever. I do have board work. So what is ICOPLAST? ICOPLAST is a confederation of plastic surgery societies. That means you are a member if your society is a member and pays your dues. Do you want to know if your society is a member? Check out our website. If you're not a member yet, your society, you can always make it happen. So that means you are ICOPLAST, and we are there for you to learn, to exchange, and to connect. So you're welcome to be active. If you've got anything, any idea or innovation, or you want to use our networks, be in touch via this email address. To keep updated, we've got a couple of ways, especially in social media. I'm going to share the links later on as well. We're on LinkedIn, we're on Facebook, and we're also on Instagram, as well as on YouTube. This is our committee that we're really proud of, the webinar committee. You can see them from all over the world. So if you're a member of ICOPLAST Society, you want to join us, just send us an email, and you're more than welcome to organize a webinar. So you can use us. Also, if you're a member society, if you're a board member of your society, be in touch. You can use our resources if you're organizing an event to make your country go global. And again, be in touch. So if you're a plastic surgeon and a member of one of our societies, you can get a certificate of attendance of today's event. We're really happy that our presenters approved to upload the videos to our YouTube channel. So you can subscribe to it. There's a couple of really interesting webinar videos up there to study if you're in the subway going to work or spending time doing nothing. Just click one of the videos. So this is actually you. As you can see, we're from all over the world today, and we're really proud of that. It really shows that we're an international organization on a global level. And we're also really happy that a lot of people from especially African countries have joined. And we hope that, always hope that we can learn from you, but we also hope that you can learn from the ICOPLAST initiative. So this is your viewer. If you want to ask any questions, there's in the lower end of your screen, there's a chat function, but especially the Q&A, the question and answering function. If you click that, you can ask questions to the panel of today. And we've got a really great panel that Julio will introduce later on. So use the Q&A. If you want to be more chatty, use the chat function. And there's a raise hand functionality as well. The future webinars, we've got a bunch of them lined up. If you have any idea, or if you have a great presenter that you've seen on other webinars, please share them with us so we can invite them to be of benefit to other people besides yourself. Next webinar is on December 4th on 5 Paris time and about noon New York time. It's about autologous breast reconstruction, the advanced basically pelvic flaps, adding volume to abdominal flaps, and also the art of the inset. I think you'll love that one as well. So please register. I'll also share that link later on. Today, we're going to hand over the reins to our president, who's Julio Kirschbaum. I'm really proud. This was his idea to organize the webinar on cleft palate surgery, and he really invited an esteemed panel. Again, before I leave, the Q&A function, use it to ask questions, and chat function. If you want to be more informal and chat with us, you're more than welcome to do so. So I'm going to stop sharing my screen and hand over to Julio. Enjoy, everybody.
Okay, well, thank you, Hinne. I want to give a very warm welcome to everybody, because we have people from all over the world. And first of all, I want to thank Dr. Hinne Rakhorst, because it was his idea about to hold these webinars that really are a good success. So thank you, Hinne. Well, now we have the opportunity. We are gonna share the experience of really two well-knowledgeable physicians that really make thousands of cases of cleft lip and palate. You know, you're gonna hear a very good experience. I have the luck of being able to work with them in volunteer missions, also with Dr. Navarro and Dr. Percy Rossell. You know, Dr. Navarro have his own group that almost in the last 30 years, you know, he visited many cities in Peru, doing an excellent job helping children with lips and palate. And the same also Dr. Rossell, you know, he worked with first with Interplus and then with research, you know, traveling all the country, and they really benefit children. So I want to thank both of them, and also, you know, to having the luck of work with them. Well, first of all, the first presenter is going to be Dr. Percy Rossell. I'm sorry, but the curriculum is very extensive, so I have to read a little bit. You know, he right now is assistant of the Edgardo Rebagliati Hospital, the Social Security in Peru. He's also study. He is PhD by the San Marcos University, the oldest university in America. He's also part of the editorial board of Plastic Cleft Surgery. You know, he is also an editorial board of the Journal of Craniofacial Surgery. And the most important for me, he's the main author of 40 scientific papers, you know, published in indexed journals. That for Latin America really it's a very important experience. Also, he's author of 7 textbooks and 2 chapters in the field of cleft lip and palate, as also winner of many awards. The most important award of Peru, that is the Hipólito Unánue Award, was won by him twice. And also right now, he's the president of the Latin American Craniofacial Association. And he's also scientific director of South American Medical Advisory of the Council of Small Train Foundation. Well, I'm going to give the word to Dr. Rossell. Then before Dr. Navarro presents, I also want to speak about him. So please, Dr. Rossell. Percy.
You need to unmute yourself,
okay.
Percy.
Sorry. Okay, it was closed. Thank you. I want to thank Dr. Julio Kirschbaum, president of ICOPLAST, for this kind invitation, and also Dr. Hinne Rakhorst. And I am very honored to share this presentation with Dr. Navarro. I am going to share my screen, okay, for the presentation. Please let me know. Is that okay?
Perfect.
It's okay?
Yes.
Okay,
Perfect,
thank you
Percy.
very much. Thank you very much. Okay. Sorry. Wait, excuse me. Sorry, I have a problem. Okay, now it's moving. Perfect. Okay, first of all, I would like to talk about the cleft palate classification. Current classifications consider these two cleft palates, for example, under the same type of classification. However, they are clearly different, as you may see here, and therefore we need a better description of the cleft deformity because they should receive a different treatment. This is the Bow classification and the Kernahan diagram, probably the most used methods for cleft lip and palate description around the world. However, they are only describing the affected segment, but not the degree of the severity. This is my personal classification, cleft lip and palate classification, and the cleft diagram, named the clock diagram. This has been studied and published in 2009 in the United States. The main contribution is the ability to describe the degree of the severity of the cleft as mild, moderate, and severe for each one of the 4 segments of the cleft: the nose, the lip, the primary, and the secondary palate. For the secondary palate evaluation, I used the Cleft Palate Index. This method represents the proportion between the width of the cleft and the sum of the width of the 2 palatal segments, measured at the level of the hard and soft palate junction. This index indicates the amount of soft tissue available from the palatal flaps and its relation to the width of the cleft to be repaired. The method has been studied and published. Based in this index, we have 3 degrees of severity: mild, moderate, and severe, as you may see here, based on the index. This is our interdisciplinary protocol. We are working doing a prenatal diagnostic using echography. Then the new worms have been evaluated by a pediatrician and genetics. And only in cases of severe bilateral clefts, we are using presurgical orthopedics when the alveolar gap is wider than 1 centimeter. At 3 months old, around 3 to 6 months, the primary chylorhinoplasty is indicated. But if some patients didn't receive any presurgical management in bilateral severe forms, we are performing a surgical lip addition in those cases. Around 9 to 12 months of age, we are performing the primary palatoplasty based on the protocol of Lima. I am presenting here in this webinar according to the type and severity of the cleft. Around 1 to 4 years, the speech therapy is mandatory. Then around 5 years, we are closing the alveolar cleft and performing any minor lip corrections. Also, if we have any severe palatal fistula, we are closing the severe forms at early age. And if it is indicated, surgery for velopharyngeal insufficiency plus speech therapy is also indicated. During the mixed dentition period, the orthodontics pre and post alveolar bone graft are indicated. Around 6 to 8 years, we are continuing with orthodontics, and also if there are any degree of maxillary hypoplasia, maxillary protraction is indicated. And finally, around 16 to 18 years old, orthodontics, orthodontic surgery, and final secondary rhinoplasty is also indicated. Regarding surgical protocols, this is important. Regarding surgical protocols, I think there are many protocols around about cleft palate repair. And now I will proceed to show you the most used strategies. This is the 2-flap method. probably the most used surgical technique in the United States and probably also around the world. The whole palate is closed in one surgical time, around 9 to 12 months of age, using 2 flaps. This is the one stage. This is the delayed soft palate closure, a 2-stage strategy popularized by Eberholm and known as the Protocol of Oslo. In 2011, this team reported a long-term follow-up observing 28% of fair and poor dental art relationship outcome. In this method, the palate is dissected on the cleft side and closed using the Bowmer flap. Then, in a second time, the entire palate is closed, dissecting both sides and using relaxing incisions as necessary. This is the paper. The delayed hard palate closure, known as the Göteborg protocol, close first the soft palate, before the 6 months of age, and later the hard palate is closed using only the Bowmer flap. Less dissection in the hard palate is required. If the soft palate is repaired before 6 months of age, then the width of the hard palate's cleft is reduced. What about the current scientific evidence regarding the use of these protocols? Here we have a meta-analysis. This is published by Stein in 2019, and this is the conclusion. One-stage repair is associated with less risk of fistula formation and BPI than 2-stage repair. Another study, this is published by Landier. This study suggests that a 2-stage closure has a higher rate of fistula formation when compared with a 1-stage closure. 2-stage around 0 to 58 and 1-stage close to 39. What about the reported fistula rate from the groups that practice the 2 surgical times method? The delayed soft palate closure had 14 to 18% of fistula rate, based on Eberholm and Summerlad publications. The delayed hard palate closure had 8% of fistula rate, based on Freire publications. Another meta-analysis, this is published by Vygotsky in 2015, find the rate of reported fistula to be around 4.9%. This is an important parameter for comparisons. Regarding maxillary hypoplasia, this is an interesting multi-center randomized clinical trial, the SCAN-CLEFT study, comparing 1-stage versus delayed hard palate closure versus delayed soft palate closure. Early findings at 5 years old concluded this. The result of these trials do not provide statistical significant difference that one technique is better than the other. Further analysis is necessary. Regarding the same study, it is the same study. This is about speech outcomes and velopharyngeal competence in hypernasality at 5 years old, and they concluded no differences were found regarding velopharyngeal competence and hypernasality at age 5 at different methods for primary palate repair. Here I'm presenting our investigations. This is an observational study comparing the Oslo protocol, 2 stages, versus 1-stage protocol, the Lima protocol, for cleft palate repair. We compared the dental art relationship, fistula, and velopharyngeal insufficiency rate at age of 5. These are our outcomes. Non-statistical significant differences regarding dental art relationship at 5 years of age between the studied groups. The same study, fistula rate in different sections, anterior and medial portion, and velopharyngeal insufficiency were not statistical significant difference between the both groups. What about relaxing incisions? Many authors have been associated the use of relaxing incision with the development of maxillary hypoplasia. But is this really true? What about the evidence? Here you have two models. The bad occlusion was obtained using a technique without relaxing incisions. Look in this case, number 1. A technique using relaxing incisions produce a normal occlusion in the case 2. But this is only a case report. We have to move to another studies. Here, the use of palatoplasty without relaxing incisions have been associated with increased rate of palatal fistulas, as you may see here in comparing the two flaps here, 0% in this study, and palatoplasty without relaxing incisions here, 16% of fistulas. In this photo, you have a post-operative view of a patient operated using the palatoplasty without relaxing incisions. The question is, if we have to do a new operation to close this fistula, this would not affect more the maxillary growth? We have to think about that. Considering our concern about the possible negative effect of this incision, we have developed a randomized clinical trial and compared two types of palatoplasty with different extension of relaxing incision. One group with bilateral relaxing incision and other group with unilateral incision. We have found non-statistical significant difference between the two methods regarding the delta R relaxation relationships during mixed dentition period. In the same study, we have found no differences between the two techniques regarding maxillary arch dimensions we may observe here. This is one group operated using bilateral relaxing incisions. You may see the occlusion and the maxillary arch form. And this is the other group, one flap. Can you see the occlusion and also the maxillary arch form during mixed dentition period? Within our understanding, what happens is this. Maxillary hypoplasia is multifactorial. Can you see? Congenital hypoplasia, effect of lip closure. This is very interesting. Many publications considering probably the lip closure is the main factor producing maxillary hypoplasia. Also effect of palate closure, severity of the cleft, dental hygiene, the hereditary factors are associated to maxillary hypoplasia. But what about the surgeon? Look at this interesting study recently published. This is a randomized clinical trial, compared different techniques for cleft palate repair and conclude this. The surgeon was the major factor that influenced the dental arch relationship outcome. Very interesting conclusion. Moving to another topic. Have you seen this complication before? They are more common than you expected and represent the most severe complication after cleft palate surgery. More than hypoplasia, maxillary hypoplasia. The palatal flap necrosis. This is producing severe sequels. This is the most traumatic experience for any cleft surgeon and must be well considered. We did a case control study and concluded that the most important predictors of palatal flap necrosis were the cleft type, bilateral incomplete, and cleft palate index, more severe forms, moderate and severe, probably associated to tissue hypoplasia. Based in these findings, we developed a new protocol to prevent these severe complications associated to the cleft palate surgeries. This is the Lima protocol, recently published at the Journal of Craniofacial Surgery. We compared this protocol with the conventional one using to flap palatoplasty, and we have found a significant reduction of this complication, as you may see here in this table. These are the protocol of Lima principles. Early surgery in one stage at 9 to 12 months, individualized treatment based on type and severity of the cleft. We are combining strengths from 1 and 2 stages. This is the first protocol in the world combining 1 and 2 stages, as I'm going to present you. 2 layers, closer without tension, reduction of the relaxing incisions to improve vascularization, not to prevent maxillary hyperplasia, non-radical intravelar veloplasty, and unilateral uvuloplasty repair. Based in this protocol for hard palate repair, we're using bipedical flaps for incomplete and bilateral, and 1 flap for unilateral forms. I'm going to present. And for the source palate, we're using furlough for incompletes and intravelar veloplasty for other forms. And we are using the unilateral uvuloplasty for the uvula repair. Now, we are going to analyze the Lima protocol in detail. What about the incomplete cleft palate? This is the blood supply to the incomplete deformity. There is not vascular anastomosis between the anterior palatine artery and the greater palatine artery. Therefore, the main blood supply to the palate comes from the greater and ascending palatine artery from the posterior port here in number 1 to 3. In addition, some blood supply is provided anteriorly by branches of the infraorbitary artery and alveolar arteries in number 5 and 6 here, but in a random pattern. Remember our classification, we have 3 types of incomplete cleft palate based on the cleft palate index. And this is the mild incomplete cleft palate. We are using here, we are using the furloughs method to repair incomplete mild forms of cleft palate. For moderate forms of incomplete cleft palate, we are using a modification of furlough, including a lateral relaxing incision, as you can see in this photo to the right. For severe forms of incomplete cleft palate, we are considering the Bollengenbeck method, using bilateral relaxing incision and preserving the vascularization from the anterior portion here, as you can see in this diagram and this photo. The palate can be closed without tension using this method. What about the unilateral deformity? Here, the blood supply is different according to the segment. The non-cleft side is well developed, and the vascularization is similar to the non-cleft palate. In the cleft side, there is not a vascular anastomosis between the anterior palatine artery and the greater palatine artery. Therefore, the main blood supply to the palate comes from the greater and ascending palatine artery. In addition, some blood supply is provided by branches of the infraorbitary and alveolar arteries in a random pattern. Remember the classification, we have 3 degrees of unilateral cleft palate. And here, the surgical technique used for mild unilateral cleft palate, according to the Lima protocol, is a hybrid palatoplasty, using a lateral relaxing incision here on the non-cleft side to repair the cleft without tension, as you may see here. For the moderate unilateral cleft palate, we use the 1 flap technique. The non-cleft side provides a big and well-vascularized flap, which is sufficient to close the cleft without tension. This technique is our innovation. described and published in the literature in 2015. In this study, no differences were observed between the use of 1 and 2 flaps regarding fistulas and velopharyngeal insufficiency. In severe forms, we are using the same technique, but we are considering an additional relaxing, small one, additional relaxing incision at the cleft side, preserving the vascularization of this segment and guaranteeing the repair without tension. What about bilateral deformity? This is similar to the incomplete forms. There is no vascular anastomosis between the anterior palatal artery and the greater palatal artery. Therefore, the main blood supply to the palate comes from the posterior portion of the palate, the greater and ascending palatal artery. In addition, some blood supply is provided by branches of the involuntary and alveolar arteries in a random pattern. Based in our studies, this type of cleft is under increased risk for palatal flap necrosis, and palate vascularization must be preserved as much as possible. Our classification, 3 degrees of severity for bilateral forms. Here, the surgical technique used for mild bilateral cleft palate, according to the Lima protocol, is a hybrid palatoplasty using a lateral relaxing incision in one side and preserving the blood supply anteriorly. For moderate bilateral cleft palate, we recommend the Bologna-Beck method. This method lets us preserve additional blood supply from the anterior portion of the palate and prevent severe complications as palatal flap necrosis, which is more common in this type of palate. The palate can be repaired without tension. We must pay attention in this type of bilateral cleft palate, the severe form. Both segments are more hypoplasic and vascularization may have abnormalities. Then the elevation of the monopedicle mucoperiosteal flap, as in 2-flap method, is not guaranteed. Ideally, the strategy here is to use a 2-stage palatoplasty. This method, when used before 6 months of age, let us reduce the cleft width. Then we may operate this palate as a moderate or mild form, preserving the blood supply to the cleft segments. What happens if the patient is arriving later? In that case, a hybrid form may be used. 1 flap in one side and lateral relaxing incision in the other side are necessary to close the palate without tension and preventing fistula development. This is the first cleft palate protocol in the world, considering 1 as 2 stages in a single protocol for primary cleft palate repair. I would like to highlight some tips recommended for all types of cleft palates. I used to mention this. The cleft palate surgery is the surgery of the greater palatal pedicle. In fact, the blunt dissection of this vascular structure is the key point to achieve the surgical outcome. As you may see here in these figures, the pedicle can be released from the foramen, guaranteeing the closure without tension. Can be easily released. This is a critical point during any cleft palate surgery. I would like to show you a video about this procedure. Okay, this is the flap. Here is the position of the pedicle. We are releasing the pedicle posteriorly. Here we have some attachments from the palatine aponeurosis, and this is firmly attached. And we have to release these fibrous attachments. Sometimes there are vessels here coming from the ascending palatine artery, must be controlled using cautery to reduce the bleeding. You can see here, the bleeding is reduced. And then using a periosteal elevator, we had to dissect the pedicle in a blunt dissection from the foramen. And this is, with careful, this is easily dissected. Can you see in the final portion of this video how this is easily dissected and the mobility of the flap is obtained and the closed can be guaranteed without tension. What about muscular repair? I like to use the furlough method for incomplete forms as I have explained it to you, but for other type of cleft, we perform the intravellar veloplasty. There are two types basically. Here we have the radical form, promoted by Brian Summerlap. This is based on the tendon of the tensor belli palatini. This is the tensor muscle, two portions, muscular and tendinous portion, and there is a tendon between them attached to the hamulus. The tendon is sectioned in a radical form, and this is not repaired. We like to use the non-radical form, considering the potential impact over the middle ear function. We use the non-radical form of intravellar veloplasty, preserving the attachment of the tendon of the tensor belli palatini. I would like to show you the technique here. Look, this is one flap technique. We are closed. The mucosa, nasal mucosa has been closed, and we are identify the fibers of the tensor tendon here. Can you see? And we are using, I like to use a knife instead of scissors, at least in this portion of the surgery, and we are separating all the muscular structure from the nasal mucosa. We have to identify here, can you see the color? It's like a kind of blue one. Okay, this is the nasal mucosa. We have to separate completely the muscular components from the mucosa. The reason is that the elevator is located in the D plane here, and the elevator must be included in this muscular component. I'm completing the dissection using fine scissors to separate the lower portion of the muscles to guarantee a good mobilization of the muscles. Can you see here clearly? This is the nasal mucosa. Can you see the color is different? The muscles were released here almost totally, and we are preserving here the attachment. We are cutting just a minor portion here, and we are preserving the attachment of the tendon tensor to the hamulus. Look at this. This is the muscles were dissected in the left side. Then we are continue with the right side. We have done here, the muscles were completely released. And finally, we are closing both segments. The right one with the left one here, using some stitches. Sometimes I'm using simple interrupted ones. Other authors like to use some mattress sutures. Then look here, we can see how the muscles are repaired, how the muscles were retropositioned without any section of the tendon tensor. Then we are preserving the middle ear function, as I am going to show in the studies. Okay, we are closing this video to continue. Look, considering I would like to present here the study. We have developed an observational study comparing the radical and non-radical intravellar veloplasty, and we observed an increased requirement of ear tubes using radical forms. In addition, we have performed a systematic review based on the following research question. Provides the radical intravellar veloplasty better functional outcomes than non-radical intravellar veloplasty? 10 studies were included. As you can see here, most of them were observational. Only this one in this group were a randomized clinical trial and concluded where better speech outcomes were observed using furlough. Middle ear function was not measured in this study. The other group, we have the same. Most of them are retrospective observational. They are not therapeutic evidence to conclude that one technique is better than the other. This one, the Antonelli, is a prospective randomized double-blind study, concluded both techniques yield similar andrologic and otological outcomes. Radical form is not better. Need for tympanostomy tube placement did not differ by type of palatoplasty. Speech outcomes were not measured. So this is very interesting to understand. What about uvula repair? During long time, we were using conventional uvula repair using the two Yemi uvulas with non-satisfactory outcomes, as you may see here. This is the original technique from Dr. Navarro. We have found some limitation in special the lateralization of the position of the uvula, as you can see here. Then we did a modification. This is the modification of the Dr. Navarro method and consists of lateral displacement of the uvula to the base of the tonsil pillar and oral mucosa C-plasty. I would like to present a video here about the technique. Look, we are sectioning the uvula here. And then we are performing in the preserved uvula at the base a small cut in the oral side, not in both sides, only in the oral side, and preserve the muscle here to preserve the vascularization of the uvula, medial incisions in both sides here, and then the other one here, the same. That's it. Then the closer. Look here, first stitch here. Then we are moving the uvula to this point. This point is located at the intersection of the anterior and posterior tonsil pillars. So we are moving the uvula laterally. This is providing a cosmetic and functional effect that I'm going to show you. I will move the video. Look, this is the stitch. I would like to, because of the time is short, look at the position of the uvula. We are closing here. Then we use the oral mucosa and move it to this point, creating an oral C-plasty. This is providing an additional lengthening to the soft palate. Look at here, there. And finally, I would like to show you the outcome. Look at the position of the uvula is midline with this modification. Look at this. It's preserved, and we are obtaining better outcomes. The methods have been studied through a randomized clinical trial and demonstrated its efficacy with better surgical outcomes than conventional method. Here you have the paper. And this is an observational study performed by us to evaluate the functionality of the unilateral uvuloplasty in bilateral cleft lip and palate patients. The technique combines intravelar veloplasty plus soft palate lengthening plus reduction of the velopharyngeal space. Look at the diagram. When the uvula is moved laterally, the volume of the velopharyngeal space is reduced. As you may see in this figure, the effects have been evaluated in this study, and we observed less rate of BPI in the group treated using the unilateral uvuloplasty. Here in the same study, we observed the reduction of the dimension of the velopharyngeal space in the operated patients and explains the functional effect of the unilateral uvuloplasty. We have some post-operatory outcomes. Look at the position and the form of the repaired uvula. We have another case here. And just finalizing here, I would like to have a few words regarding bleeding, because this is probably the most common postoperative complication. Conventional treatment is the intraoperative hemostasia, but sometimes this is difficult to be performed and difficult to be controlled. I use a follow catheter balloon for palatoplasty bleeding management. We reduce significantly, as you can see in this study, the reoperative hemostasis using this method according to this study. I would like to finalize this presentation showing my last textbook. All the techniques presented here are well described in my publication, edited by Springer and accessible, available for you this year. Thank you very much for your attention.
Thank you, Dr. Rossell. Very interesting presentation. I hope everybody enjoy it. But now I have to introduce the second presenter, is Dr. Carlos Navarro Gasparetto. He trained first as a cardiovascular surgeon with a famous surgeon DeBecke in Houston, Texas. But then he switched to plastic surgery. He trained at Baylor, also in Houston. And he worked with at that time with the first team that developed the mammary implants. Then he came back to Lima, but also established private practice in Florida. So for some time he was working in two countries, Peru and Florida. He's doctor of medicine in the University of Miami School of Medicine. He also is professor of plastic surgery of the University Peruana Cayetano Heredia. He's a certified in two countries by the American Board of Plastic Surgery. He was president, ex-president of the Peruvian Society of Plastic Surgery, ex-president of the Latin American surgeon that work in the States. He's also president of CIRPLAS, that is, that I talked before. It's a volunteer group that travels all around Peru, usually on a monthly or twice a month base for many years. And he also was president of many meetings, and he was president of the Latin American meeting in 2000 here in Lima, Peru. He gave plenty of talks, around the world in many fields, and he has as I told, experience of thousands of patients being operated. So I give the word to Dr. Carlos Navarro, please.
Thank you, Daniel, for the introduction. I will proceed with my presentation because we don't have too much time left. ¿Qué pasó? No, está bien.
Comparte la pantalla, Charlie. Compartir la pantalla.
Espérate un momento que tengo un problemita acá. Tenemos que regresar donde está la... Acá abajo. Aquí. Ahí. ¿Dónde está la presentación? Ahí. Ya, está la ves, Daniel.
No.
¿No se ve?
We don't see it.
Share screen. Acá. Ahí. No, acá. Ahí. Ya. Share screen. Hay otro. Hay otro ahí abajo. Acá. Sí. Ahí.
Hay un botón verde que dice Share Screen.
Share. Ahora sí entra tu presentación. Ahí, la última. ¿Ahora lo ves? Ahora sí.
Pero no se ve el trabajo.
¿Se ve? ¿Lo ves ahora?
No, el trabajo no. La pantalla se ve negra.
Qué raro. En antes la vieron. Share screen. Ahí entra. Share.
Listo. Ok, agranda la pantalla, Charlie.
Ahora se ve.
Perfecto, perfect. You
Yeah.
can go.
Okay. Bueno. I will start now. I have nothing to disclose. All current methods for the cleft palate closure use lateral relaxing incisions. I was taught the Bo-Kilner-Wardell pushback. That was the first technique that I used as a resident. But the problem with this technique is that it leaves raw areas. Raw areas heal by secondary intention, and they cause scar contracture and maxillary collapse. Many papers have documented this fact. These are some of them. So I prefer to avoid relaxing incisions or at least minimize them. These are two patients that I operated at different times in my career. The one on the left, I used relaxing incisions, and the one on the right, I did not use relaxing incisions. With the one that I used relaxing incisions, that was at the beginning of my career. This is what I got. I got dental arch deformities, malocclusion, and maxillary retrusion. This is without the relaxing incisions, and you can see the difference. This profile looks normal. Now, in this case, early in my career also, I used extensive relaxing incisions to close the bilateral cleft lip and palate. You can see in the profile that at the end there's retrusion. This is without the relaxing incisions, and you can see that development is normal. Now, how do I do the repair without relaxing incisions? Of course, I infiltrate the palate with tumescent technique using lidocaine and epinephrine to cut the bleeding. And then the incisions are made on the cleft edges. Then I elevate the oral mucoperiosteum, and through the incision, retracting the flap, I can identify and preserve the neurovascular pedicle. Now you can see in the nasal mucosa, I use a large bomber flap to close the nasal layer. Then I can approximate the mucosa, the oral mucosa on both sides. You can see that it even goes across the midline. The reason I can do that is because when you dissect on the hard palate the mucoperiosteal flaps, you free them from the bones, and then you bring into the horizontal plane. They can be closed in the midline without lateral relaxing incision. The bilateral cleft, the same thing can be done. You need two bomber flaps to close the nasal layer. Now, as far as the muscle orientation, in the normal palate, the muscles are reoriented transversely, whereas the cleft palate, they're anterior-posterior in direction. So that has to be fixed. So what we have to do is liberate the muscles and displace them posteriorly. We can see in the diagram and also clinically. This adds length to the palate. And then we form a transverse muscle sling, which is very important functionally. I think Percy has already talked. So then, for the hard palate, I use a bomber flap on the nasal layer, and then follow that with the oral mucosa closure. You can see here the only incision in the midline. There's nothing on the sides. In the soft palate, there are 3 layers: the nasal mucosa, muscle, and the oral mucosa. You can see here the patient before the operation and after the operation. The scar mimics the medium raphe. When you finish the closure initially, the palate flat. After a few weeks, it regains the concavity, the normal concavity. Now, what happens when the cleft is too wide and you cannot close it? Then I use a dentoalveolar sulcus release. That is a natural space between gum and teeth. The gum then is separated from the alveolar ridge and it becomes a lateral extension of the oral flap. When you do that bilaterally, the other flaps can very easily be switched together to close the clefts. Of course, in the unilateral cleft, sometimes only one side has to be done. That's enough. But if the cleft is bilateral, especially if it's a very wide one, you have to do it bilaterally, that you can close the cleft. Now, then the open spaces on the sides can be closed completely or at least partially, like it is done orthodox 2-flap technique. As far as the uvula has been formed by suturing the hemiuvulas together for a long time. As Percy mentioned, I developed a form to prevent bifidity of the uvula. It can be prevented. The way I do is I take one of the 2 uvulas and I centralize it. Usually the one that is most posterior or the biggest one of the 2. The other uvula, I don't discard it like Percy does. I will show you what I do with that, but I incorporate it into the repaired transverse. That also helps lengthen a bit more. Yeah, of palate. Okay, schematically, this is the transverse cap. The uvula that I will incorporate transversely, I cut it horizontally so that there is a nasal flap and there is an oral flap. And here we close the nasal layer. This point will go to that point, and then you have the centralized uvula, which always looks normal. I think that an ounce of prevention is better than a pound of treatment. Thank you. That's it.
Okay. Thank you very much, Dr. Navarro. So, excellent presentation. So then there are many, almost 400 attenders. So there are some questions. So I will read you their questions. We cannot do it openly, but I will tell the name and the question. First of all, it's a question. It's to Dr. Rossell from Mani Nordesai. What is the presenter view on using a primary buccal flap, especially in case of wide cleft palate?
Ahora tengo que esperar las preguntas.
Sorry, thank you. Actually, there is using more this buccinator flap. Dr. Mann promotes the use of the buccal flaps for primary repair in a kind of wide cleft palates. My personal point of view, I think we can close any type of palate independent of the cleft width, but I always considering not only the width of the cleft, also the width of the palatal segments. That is the reason why I use the palatal cleft index. This is the proportion between the cleft and the sum of the two palatal segments. Then you have an index. This is indicating how much tissue you have to close the cleft. And based in this classification, you can select the technique, and any type of cleft, independent of the width, can be closed. The use of the buccinator should be reserved to be used for secondary times, for secondary complications like fistulas or velopharyngeal insufficiency, if you like. But I don't agree more about the use of primary, because also there are close to 30% of complications associated to the use of buccinator flap. This is not simple surgery. This is extended surgery. At early age, I don't think maybe a good idea. So I don't like to use it primarily.
Okay, thanks, Dr. Rossell. Then is another question from Leiki Khalid to Dr. Navarro. So, Dr. Navarro, in case of unilateral uvuloplasty, if there is any lateral displacements or uvula or no, as muscle there is just for bulk, so while gaining length, we compromise bulk or not?
Well, actually, you have to be very careful in centralizing correctly the uvula. If it's not correctly centralized, then in the post-operative period, you can see it that it is to one side or the other, and that needs to be corrected later. So you have to be very careful that at the time of the primary surgery, you have to place the uvula exactly on the midline.
Okay, please, Dr. Rossell.
I would like to compliment that I think the idea is great, really, because this is a common problem. When you are using two uvulas, the two yeme uvulas, it's very, very difficult to get a new one because there is a retraction. It's very common. So in that way, I think the idea of Dr. Navarro was really great. But when I've been performing at the beginning, that the problem most common non-desirable outcome is that the lateralization of the uvula. That's the reason why I have modified the original concept. And I think the critical point to move the uvula centrally is the location of the end of the tonsil pillars, where the both tonsil pillars, the anterior one and the posterior one, ends at the top of the tonsil. I think that's the point. If you cut there, you may obtain a proper position of the uvula. In addition, this is reducing the velopharyngeal space. That's the reason why I have considered this technique not only cosmetic, it's also functional.
Dr. Rossell. Well, there is another question to you, Dr. Rossell. If you can explain more the double opposed and furlough palatoplasty as against the velo palatoplasty.
Okay, I think the question is not clear really. They are asking about comparisons between other types and furlough, probably. But if we are talking about primary repair, it's quite difficult to start doing furlough in complete palates, unilateral or bilateral. It's difficult because sometimes the cleft is wide and it's difficult to move the flaps. And also, I have to be very clear in this point. I have seen severe complications related to furlough with necrosis of the soft palate. Because this is really, really, really bad. Because if you have a hole in the hard palate, you can close it because you can use fan flap, buccinator, tongue flap. But if you have necrosis of the soft palate, the muscles are not there anymore. So we have to be sure. I would like to recommend that the use of furlough should be used for incomplete forms of cleft palate. It's more easier to be done in that cases, or to be used as a secondary correction of the velopharyngeal insufficiency. I think in that way it's good. If you can correct the other forms of palate of cleft palate, the unilateral completes and bilateral ones, using intravelar veloplasty. I think probably the velopharyngeal insufficiency is close to 10%. I think that's acceptable. And you can correct and obtain an anatomical and functional correction doing this protocol without any problem. That's, I think, I would recommend furloughs for only those cases.
Okay. Then the next question for Dr. Rossell also. I am very interested in one flap method, using relaxing incision. How deep is the incision and what is the extent of the dissection? Do you dissect only in soft palate or in the non-flap side?
Thank you very much for the question. This is really an innovation. Some authors, some other surgeons, they said, this is not an innovation. This is the Clark method. I don't agree, because the Clark method is the hybrid palatoplasty, and he's elevating the cleft side. He's using a flap from the cleft side, which is the smaller one, and also is hypoplasic. To me, there is no reason. I have changed that concept, and we are using only the big one, which is normally developed and well vascularized. And we are using the flap from the non-cleft side. About the question, this is an important introduction. And then, what happened? The incision. There are different locations. Dr. Navarro mentioned the location over the gingiva. It's a lateral one. That it was described by Cartens. I've been using that incision in consideration that the flap is bigger, but I have seen problems because the herms, the dental tooths inside, who is going to be growing later, are exposed. And some patients have, I have seen that, severe pain, dental pain. The babies are crying and crying because the tooths are exposed through this incision. So I have changed. Actually, I move it medially, the incision. Between what? The conventional one, between the palate mucosa and gingiva, I move it a little lateral, but not exactly in the line of tooth eruption. That's the incision. The incision is extended 1 or 2 centimeters over the soft palate, and I am elevating the whole palate on the non-cleft side, a blunt dissection of the pedicle, and I am performing a subperiosteal dissection of the cleft side and elevated in the subperiosteal, but I'm not using relaxing incision, at least in the severe form. I'm using a small one to prevent fistulas. But I have to do as a periosteal dissection at the cleft side. But remember, this is not limiting the excision just because of the maxillary growth. I don't agree with Dr. Navarro in that point. I don't think that the relaxing incision is promoting the maxillary hypoplasia. This is multifactorial. That I'm doing is limiting the relaxing incision to improve vascularity, because the most terrible complication in cleft palate surgery is not the maxillary hypoplasia, it's the palatal flap necrosis. If you lose the palate, as you can see in pictures I am presenting today, then what can you do? It's very difficult to be corrected, and probably never can be corrected or were corrected, probably. So it's very interesting to consider now this complication more than maxillary hypoplasia. In that way, the Lima protocol, this Peruvian protocol, is the new one considering 2 stages and 1 stage, and improve the vascularity of the flaps. Because this complication, I'm sure you have seen this problem. And this in missions is more common. And it's very difficult to be repaired. I think we have to think about not only about fistula, not only about maxillary hypoplasia, also palatal necrosis, and also audiological outcomes. These are not well measured in studies. That's the reason why we are doing a non-radical intravenoplasty. Thank you.
Thank you, Dr. Rossell. Now we have another question for Dr. Carlos Navarro. Dr. Navarro, do you have maxillary hypoplasia in cleft patients with non-relaxing incisions?
Actually, not really. The ones that I have seen in my practice, like I showed during the lecture, are the ones that I use extensive relaxing incisions. In the other ones, the development is nearly normal.
Dr. Navarro, there is another question for you, Dr. Navarro. Do you mean the question that they make is Fuad or sick? He made you this question, Dr. Navarro. Do you mean that pushback procedure is actually banned because of its results?
Can you repeat the question? There was some interference.
Yes, that you mean that the pushback procedure is actually banned, que no sirve.
Okay, well, I think that, you know, I read a number of papers where they discuss this problem. And what they say is that with time, most of the length that is gained by the procedure will be lost due to contracture. So I don't use that procedure anymore.
Okay, fine. There is also another question for you, Dr. Navarro. Of course, I am not saying, but in all the comments, they say they like the presentation, they say excellent presentation, thanks for the presentation, but I just go to the question. Well, Dr. Navarro, and that also can be for Dr. Rossell. Do you use osteotomy of foramen for wide palate to move the flaps and indication in regard to the age of the patients, Dr. Navarro?
I started using that. I had learned that from Dr. Ian Jackson, who learned himself. He learned that from people in Sweden. Tord Skoog, he describes that. And initially, I have done that a few times, but since I started doing the dislocation of the lingual gum, like I showed, you know, I don't need that because the pedicle doesn't hinder me from doing the repair.
And Dr. Rossell, what do you think about?
There are short comment. The pushback is the Bow-Wardle killer. Okay, that technique is moving the palate posteriorly and leaving a big raw area. Most of the studies, actually, the evidence are indicating that this is the most, this technique has the worst outcome really in relation to maxillary growth. That's the worst technique, the pushback. I think the muscles through the furrow or intravellar valvuloplasty can be repaired without any problem. In relation to the release of the pedicle using osteotomies, I never do that, really, because the pedicle can be completely released doing a blunt dissection of the structures around the pedicle. Because the problem is that the pedicle is firmly attached to the foramen through these structures. This is a fibrous structures coming from the aponeurosis. And this is firmly attached. You can, as I showed you in the video, you can elevate the pedicle carefully, totally, and probably this can be elongated 1 or 2 centimeters without any osteotomy. The osteotomies are affecting the growth there. The osteotomies are including some other complications like bleeding. And in my understanding, this is an old method, and this is completely unnecessary.
There is also a question for Dr. Navarro, and also for both, because they ask any. So maybe you answer first, Dr. Navarro, and then Dr. Rossell. Where are the limits of intravellar incisions technique? And what is their opinion about transversal section of the nasal layer for lengthening of the palate?
Okay, I never do that. And my dissection is always very limited. You know, I am a proponent of minimal incisions for everything in surgery. Can you hear me?
Yes, sure, perfect.
Yeah, you know, the modern tendency in surgery, in all types of surgery, is try to prevent large incisions. So this is what I do. On the lip, I also use only a single incision, a vertical incision, and with a muscle repair, I can fix the lip and get a good result. So when I work on the liberation of the muscles in the palate, I also liberate only what is absolutely necessary, and I don't do anything more. Obviously, I never do a radical intravelar valvuloplasty as Percy showed, and he agrees with me on that it's not necessary. We can do it without that.
Dr. Rossell?
Okay. This is an old concept, really, because the idea that the palate should be lengthened to obtain competence is coming from pushback, because the pushback, the Bow-Wardle killer, is the technique moving the palate forward, posteriorly. And other authors like Durance were cutting the pedicles to move the palate totally in the posterior portion and lengthening. But this is an old concept. So the studies were evaluating the relation between the lengthening of the palate and the function. And there is not a direct relation between the length of the palate and the function. There are shorter palates with good function. And also there are long palates, not functionally. A good example is the velocardiofacial syndrome. The palate is long, but this is not moving. So we have to think about what we are measuring. I think if we want to lengthen the palate and we are separating the nasal mucosa, as the question is presented here, doing a kind of lengthening to promote function, I think it's not a good idea. First, because of that I mentioned it, that not necessarily the long palate there is a better function, not necessarily. Second, we have to close the palate in 2 layers, oral and nasal. This is the best way to guarantee prevention of fistulas. Okay? Also the tension of the closer. But if we are separating nasal mucosa and closing only the oral side, we are closing in 1 layer. And this is just the worst location, because the point between the hard and soft palate is the location of the more common location of the fistulas. So I think we are promoting fistulas, and I'm not sure if you are lengthening the palate, you are obtaining better function. A proper reconstruction of the muscle is the best way. Probably in a few cases, but I think not agree with that procedure, really.
Okay, fine. Thanks, Dr. Rossell. There is then another question for Dr. Navarro. The amount of cleft palates that are really challenging to close is not to be underestimated, even with the use of relaxing incisions. How often does you need to perform the gum relaxation? Does direct repair without relaxing incisions for the most of the patients?
Like I said, I don't use relaxing incisions. What I use is, you know,
No, they speak, Carlos Navarro, about gum relaxation. Gum, yeah.
Yes, I use that all the time. And I didn't have the problem that Percy has had with that procedure. And I think the vascularity is very superior when you don't use the classical relaxing incisions.
Okay, fine, thanks. There also is another question for you, Dr. Navarro. Is closing oral palate in a horizontal plane can leave a space between the nasal flap and the oral flap? If there is any problem associated with the presence of that space?
No, there's no problem, because like I mentioned briefly, you know, when you finish putting the flaps together, and you look at the palate, it's flat. There's the normal concavity is lost because of that big space. But that you don't have to do anything. The palate itself will fix, you know, the concavity, regain the concavity after maybe 10 or 12 days. And you don't really have to do anything.
Okay.
You know, when they speak about the furlough procedure, he does that all the time. And he published his technique, and he said that dead space will not cause any problems.
Okay. Well, we have 5 more minutes, but we still have time for 2 more questions. So first, to Dr. Rossell, please, they ask if you can help in tips in dissection of the greater palatine artery.
Okay. First, I have to be familiar with the location of the greater foramen. Okay, that's very important. If you start the dissection at the top of the patient, and you are dissecting the flap in a mucoperiosteal level, you can easily observe a spine. This is a maxillary spine. This is, in all cases, you can maybe in syndromic cases, this is not present, but in non-syndromic patients, you can see easily when you are dissecting, going forward, you are observing this spine. Behind the spine is the pedicle. It's very easy to, this is a very important tip. When you identify the position of the pedicle, then you are moving around the pedicle, medially and laterally. The medial dissection can be easily, and you are turning and doing the dissection over the palatal bone. The attachments are strong in the lateral portion of the pedicle. That is the dissection I show you in the video and should be performed carefully. I used to do this dissection at the end of the surgery to prevent bleeding during the surgical time. But if you identify the spine and you are doing the dissection around the pedicle and release the attachments, these fibrous attachments, you can move it, the pedicle, 1-2 centimeters. The dissection should be done carefully by blunt dissection, and it is important to be well trained, because if you don't have the hand to move it slowly and firmly, you may cut the pedicle. I had never had this problem in my practice, but this could happen. So we must have careful attention in this point.
Then I will make a...
Dr. O'Neill, there is a question about Dr. Summerland radical intravertebral veloplasty.
Yes. You want to answer? Answer.
Yeah. Oh, yeah. Okay. Thank you. The question is Summerland performs radical release of the levator. How do you see it as you prefer limited dissection? The point is this. Dr. Summerland is promoting the delayed soft palate closure and also the radical intravenous veloplasty, but this is based on observations. I know Dr. Navarro is presenting long-time experience and he's observing the outcomes related to the incision or non-incision, but we must follow the scientific method, because the evidence is the only objective way to compare and demonstrate any therapeutic evidence. If we don't have that level of evidence, it's just an observation, opinion of the expert, cannot be compared, and we must take this carefully. In the case of Dr. Summerland, he presented the radical form of dissection, but through observation. In the paper in Plastics and Reconstructive Surgery, he is presenting and he is reporting few complications. And that's the reason we developed a systematic review. And there are no evidence, therapeutic evidence in the literature comparing radical forms against non-radical forms. If you understand that the tensor of the velo palatini is in relation with middle ear function, we clearly understand that we cannot cut it just and leave it without repair. I've been in one country close to Peru in a conference, and the ENT there reported 90% of complication or audiological complications in the patients. And this group of patients were operated doing radical forms. So I'm not saying now that the non-radical is better than non-radical, because at least I have to do a clinical trial. But I can say now that there are no evidence proving that the radical is better than non-radical. So I think if we can preserve the structure, it's better. If you perform a radical form, then you cannot correct. You cannot reposition it in a secondary procedure. It's very difficult. But if you do a non-radical form, then you can do a radical one if you consider later as a secondary procedure. I think in many ways, it's better to perform a non-radical form. That's my position.
Okay, thanks. Dr. Navarro, you want to comment?
I agree with Dr. Percy Rossell on that point. We have some differences, but I agree on that point. I think that we should preserve function. That's the most important part of the procedure. Aesthetics is fine, especially for the uvula, but you have to preserve function. That is very important.
Okay, fine. Yes.
Just final comment, because I think there is a big emphasis in this kind of protocols, differences. For example, 2 stages and 1 stage. That this is maybe is the main communication in my presentation. At the same situation with the relaxing incisions or not, but we have to consider if we are performing a technique leaving the patient in higher risk of fistulas, like 2 stages, or not using relaxing incisions, then we have to come back and repair the fistula. My question is, if you need an additional surgery, is this not affecting more the maxillary growth? Of course. If you are performing 3 surgeries, 4 surgeries, it's affecting more the maxillary growth. So we have to do it in one shot. This is one point. The 2 stages, through the meta-analysis, have demonstrated that the rate of fistulas is increased using 2 stages. Then you have to do an additional surgery, even if it is small. So we have to consider carefully any technique, and we must privilege the speech and fistulas before maxillary hypoplasia, because maxillary speech you have only short time because should be corrected at early age, but the maxillary hypoplasia can be corrected, well corrected, using orthodontic surgery, but the speech not. If you lose the time to correct the speech, then probably the patient never speak well. So I think that's the reason why in the United States, they are using 1 stage and they are using relaxing incision because they prevent fistulas. Think about that.
Thanks, Dr. Rossell. Well, the last question, because we have to finish. So both can answer. It's an important question also from Natalie Roche. First, you answer Dr. Navarro and then Dr. Rossell.
Okay.
Here's a could the speakers comment on the postoperative protocol, feeding, use of antibiotics, use of nasopharyngeal tube, and other things. So, Dr. Navarro.
I do use antibiotics after surgery for maybe 3 or 4 days. I don't know if that's something to do or not, but it seems to help. What was the other question?
Oh, if you nasopharyngeal tubes.
No, I don't use nasopharyngeal tube.
Yeah. And when they can start feeding?
As soon as they wake up from anesthesia, I start feeding.
Okay, thanks. Dr. Rossell?
Yes, it's an interesting question. There are some clinical trials about feeding, okay? The use of spoon, syringe, or other types. But this is very, very interesting because first, the patient can leave the hospital when the baby is eating, okay? It's the recovery and is eating. This is very important because sometimes the baby, in especially missions, the baby is going home early in a short time. This is a lip surgery. Okay, go home. The problem is when the mother is starting doing the food, the baby may get some aspiration. If a 3-month-old gets an aspiration, the baby can die. So feeding is not a minor issue. It's a very important one. What I recommend is not the syringe. We have a case when the baby was in the hospital and during the midnight, the nurse take a syringe and provided the milk to the baby and get an aspiration, and the baby died. Because the syringe, when you are not using properly, you are providing a shot of food and going directly to the larynx. So please, must be used carefully. I prefer the spoon because it's more easily, and the baby is accepting the food. I think this is very important. Second question, in relation to the tubes, I'm using ventilation tubes only when I'm performing pharyngoplasties or pharyngeal flaps for velopharyngeal insufficiency. Then in that way it's necessary because we are creating a reduction. In the primary cases, I have to point it that when you are performing radical forms, you may create an obstruction, an important obstruction, and you may have problems in the post-operative time, especially when you have radical forms. There are radical forms with overlapping of the muscles. This is creating a tightness and a reduction of the velopharyngeal space. In that case, I would like to use ventilation tubes. Right, I agree. If this is a conventional repair, as I presented here, as Dr. Navarro presented here, there is no reason to use ventilated tube because this is anatomical repair. I think I will recommend to take in consideration that situation. Thank you.
Thank you, Dr. Navarro. You know, we have to finish. I think were excellent presentation. We all learn a lot. I hope to the rest of the audience that you enjoy these two excellent speakers. And before we adjourn, I want to say there are many questions about where you can see the recording of this conference, and you can find it in the chat. You will see that in LinkedIn, in Instagram, in Facebook. It's in the chat, so without any problem, you can find it. And also, you know, you are almost very welcome to the next webinars of ICOPLAST. So without nothing, I also, well, I don't read, but there are many thanks for the presentations. So so goodbye to everybody. Hope to see you soon. And thank you, Dr. Carlos Navarro, and thank you, Dr.
Thank you.
Percy Rossell, for the fantastic presentations. So bye to everybody.
Thank you.
Dr. Daniel.
Bye-bye.
I'm leaving in the chat my email because there are many questions there. Maybe somebody may write me. Thank you very much, Dr. Daniel and ICOPLAST for the opportunity. Thank you. Thank you, Dr. Navarro.
Okay, Dr. Navarro, you can say goodbye.
Bye-bye.
Bye-bye. Bye.
Goodbye.
Bye.